recent advances and developments in STI, RTI, and HIV/AIDS. So I work as professor and consultant microbiologist at the Apex Regional STD Center, which is a center that is exclusively dedicated to the diagnosis and management of STDs and HIV/AIDS. Next, please. If all of you as PGs thought that STD is a topic which is very small and maybe it'll just be a short note and you can read it just a day or two before the exam, please think again. Look at this report from WHO, which says that they are on the rise, and you can even get a main question, a 10 marker or something, because HIV/AIDS and STDs, the recent advances, can be a very important topic. Next. So some of the, just by way of introduction, I'll just run through a few of these slides. The ground reality of STI services in our country is that the number of people infected, that means the people in the community who are infected with STDs, any of the STDs, far outnumbers the number of people who are screened, diagnosed, treated, and cured. So it is definitely a very big public health problem. Next, please. Yeah. So, what is the importance of diagnosis of the STDs, and just a little bit of introduction about the importance of diagnosing them early and all the newer diagnostics. There are just over about 30 known pathogens causing STIs and RTIs. STI is sexually transmitted infections, and RTI is reproductive tract infections. Now, the asymptomatic infections are very common. So that's what we have to target. So much so that WHO has changed the word from, earlier it was called as VDs. The earliest term used was VD, that is venereal disease. So it's after the Greek goddess of love, that is Venus. So venereal disease gave way to the newer term STDs, that is sexually transmitted diseases. But now it is sexually transmitted infections. What's the difference between the two? When you say disease, the person is already infected and they are symptomatic and they come to the hospital with the problem. So that is the stage at which we see them usually in our clinics, that is STDs. But we have to catch those who are asymptomatic and transmitting the infection and spreading it in the community, that is at the stage of the infections. So the term STI is what is used now, so rather than STDs. And there are more than 1 million curable STIs that are acquired daily worldwide. And an estimate also says that there are 374 million new infections in the 15 to 49, that is the sexually active age groups. And the 4 important curable STIs are the chlamydiasis, gonorrhea, syphilis, and trichomoniasis. And the people living with HIV is said to be almost about 40 million. And what has caused the increase in STDs over the last couple of years or decades? Mostly it is due to international travel, social networking, increasing connectivity, and changing sexual behavior. So that's why we have these newer causative agents coming up every other day. And complications in women and newborns are also increasing, and which are very, very important to address. Next, please. So what we see is only the tip of the iceberg. That is the symptomatic cases which actually come to our STD clinics in the hospital, more males than females, of course. This is only a tip of the iceberg. There is a large chunk of asymptomatic people, mostly women, lying in the community that we have to tap and treat. Next, please. So this is it's the same with the HIV infections also. Around 40 million infections are present according to the 2023 estimates, and out of which you find that the people with asymptomatic HIV infections, they form the large chunk, and the people with actual full-blown AIDS is a very small fraction. So that must tell you how important the issue is. So what are the what is the role of the laboratories in STIs? The laboratory in STIs is not just for diagnosis. It is for screening, especially the asymptomatic high-risk groups, HRGs, and for diagnosis of atypical cases, and for multiple infections and mixed infections, which are usually not caught by the clinicians, and the asymptomatic infections, of course, and for monitoring treatment, for surveillance, for outbreak investigations, for syndromic validation and detection of antibiotic resistance, and of course, research. So, when we say syndromic validation, what is this syndromic validation? The syndromic management, as you all may be knowing, that is the management of cases of STIs in the clinic by the clinician just by looking at the symptoms and clinical examination without any laboratory tests. They straight away give the treatment. So we'll see how or why this is not that useful and what the limitations are over the next few slides. Yeah, going through the overview of laboratory diagnosis of STIs, like all other diseases here also, we have the conventional methods of diagnosis are direct microscopic demonstration of the organism by way of maybe a wet mount, a dark field microscopy, or stain smears, or you can culture the organism and isolate it and then identify it. That's the conventional method. You can also resort to serological tests for detecting the antibodies, or sometimes the detection of microbial antigens also, and then detecting the microbial metabolites in some of the things. These are indirect ways of diagnosis like pH and whiff test and all of this. So these are the conventional methods. But now we need to know what the recent advances are and what else is available. Next, please. So, what is new? Now we'll come to today's topic. So, I will be dealing with this topic in the following headings, that is, what is new in STI pathogens, and what's new in the diagnosis, what is new in STI treatment, prevention, HIV/AIDS, and some of the new aspects in public health interventions, and lastly, the WHO recommendations. It looks like a lot of topics, but let me see how quickly we can go through with all of this. Next, please. So, firstly, what are the newer pathogens? So, there are some organisms which have recently been included as STI pathogens. Mycoplasma genitalium was being talked about as an STD pathogen, but now it has increased in numbers, and especially in vaginal as well as anal sex, because anal sex, oral sex, it's much more common nowadays. We are getting a lot of cases, and it can infect the cervix, urethra, or the rectum. And although it is not the commonest cause of non-gonococcal urethritis, it is becoming an important cause of non-gonococcal urethritis, or NGU. The commonest, of course, is chlamydia trachomatis. And the other important thing about Mycoplasma genitalium is that it is resistant to azithromycin, which are the drugs of choice. Presently, azithromycin is being given. And the fact that it cannot be cultivated very easily means we can only resort to molecular methods like PCR for diagnosis. And in our country, mycoplasma studies are mostly not being done in too many labs. As far as I know, I think Dr. Sunil Sethi in PGI Chandigarh is working on this, and Dr. Benu Dhawan in AIMS. So otherwise, other labs are mostly doing only molecular diagnosis. And there is another surprise organism which has been implicated in STIs, that is Trichophyton mentagrophytes. As late as 2024, just last year in the United States, this has been declared as one of the newer pathogens in STIs because it causes it has been proven to cause sexually transmitted fungal infection. It's called as TM7, subtype 7. V11 is the Roman number 7. Okay. And LGV is already a known pathogen, but now the newer infections that it can cause is colorectal strictures and fistulas because of anal sex. Okay. So this is the newest addition to what LGV can cause. That is chlamydia trachomatis, L1, L2, L3 can cause. And then there is supergonorrhea. We know about gonorrhea as one of the oldest STIs known to mankind. But now the supergonorrhea, or the gonorrhea, why is it called supergonorrhea? Because drug resistant gonorrhea is becoming very common, and this is a growing concern. So this again can be considered as one of the newer pathogens. Next, please. So apart from that, I've given an entire list here of the emerging and re-emerging STIs. You have the categories of bacteria, virus, fungus, as well as parasite. And you may note that some of these are the intestinal pathogens, that is Shigella, then you have Entamoeba histolytica. So all of these causing STDs is because of the sexual habits and the sexual behavior like anal sex and all that. Okay, and so you can see most of them are common in MSMs. I've written MSM in the columns here. That is men who have sex with men. Okay, that is homosexuals or men who have sex with men. And you may be surprised to see that there is group B streptococcus, and even MRSA has been proven now, and dengue virus also. Dengue, monkeypox, Ebola, all of these viruses, they have been found in the seminal fluid and the vaginal fluid. And in 2019, dengue virus was even proven in Spain to have caused the STIs. So this is the list of the newer pathogens. Next, please. So let's go to the diagnostic aspects. Syndromic management, as I mentioned earlier, it is without the help or the assistance of the laboratory, the clinician gives the treatment. This may be very good in the PHCs and centers where laboratory facilities are not available in remote areas and all that. So the advantages are it is cheap. You don't have to wait for a laboratory test result to come out, and the treatment and the diagnosis and treatment is done in the same visit. All these are advantages, but there are several limitations to this because asymptomatic infections, they may not be coming to the clinic, so you're missing all of them. And if they are mixed infections or multiple infections, because if when a disease is sexually transmitted, if you can get one, you can get another, so you can have more than one infection. So these are all missed by the syndromic management. And of course they promote drug resistance, and sometimes it leads to over treatment. And according to a WHO estimate, they say 27% of the women with vaginal discharge syndrome are not diagnosed by the syndromic case management. So because of all this, the diagnosis has to be improved. Next, please. So what are the characteristics we want to consider when choosing a diagnostic assay? When we think of diagnostic assays, these are all the following points that we look for in a good diagnostic assay. Sensitivity, so that we don't miss people with infection. Specificity, to exclude people without the infection. And positive predictive value, the negative predictive value, the complexities like what are the equipment required, reagents required, the staff required, all of that, and the cost factor. Then the throughput, that is how quickly the results can be, how many tests can be done at a given point of time, and how quickly the results can be got. So these are all the characteristics that we look for in diagnostic assays. Next, please. So recent advances, we find that the diagnostic assays, they have improved now with the rise of all the machines. They have been the game changers, especially the molecular tests. I'm talking about the nucleic acid amplification tests like PCR. So this is like a Xerox machine. You can pluck a DNA needle from a haystack. So that means even when the number of DNA or the nucleic acids are very minimal in number in the sample, you can still pick it up with these powerful molecular tools. And now we have a lot of improvements in these, like they're making it into point of care tests, and there are other principles of tests involved. They've moved on to microfluidic assays, the microarrays, sequencing, next generation sequencing, the omics. So all of these, like in the other diagnostic tests of other diseases, STIs also, they have not lagged far behind. We are also using all of these for diagnosis. Next, please. So the applications of molecular diagnostic methods, we can see what the newer methods are. Next. Yeah. So firstly, the NATs, that is the amplification tests, the conventional PCR and all of that. They are now considered gold standard for many of the STIs. For example, chlamydia trachomatis, herpes simplex virus. It is widely used. In fact, it may be the only test used because they are difficult to cultivate, and you need the tissue culture and all of that to culture them, to cultivate them. So the NATs have become the gold standard. They have, the advantages are they have high sensitivity and specificity. So this makes it very useful for them as screening tests in asymptomatic cases. See, the entire lecture, I have been stressing a lot on these asymptomatic cases because that is where the control measures lie. Okay. And you can also pick up the extragenital infections, like, for example, in CT, NG, and MG, that is Chlamydia trachomatis, Neisseria gonorrhoeae, Mycoplasma genitalium. And you can also detect from non viable organisms because you are looking at DNA and picking up DNA or RNA and all of that. So, even non viable organisms, you can make a diagnosis, unlike in culture techniques. And non cultivable organisms like CT, MG, TP, TP is Treponema pallidum, and many of the viruses. So here, the non-cultivable organisms can all be picked up by gnats, and it can also detect from less invasive samples, like for example, from urine samples. You cannot imagine getting a positive culture with a urine sample, but gonococcus can be picked up from a urine sample if it is done by the gnat techniques. And you can even differentiate between some closely related organisms like HSV1 and 2. So PCR is one test which can distinguish between the two, differentiate between the two. And you can also do multiplexing. We'll go into that later. And it lowers the turnaround time. So there is speed. There is it can be automated, and you can also design them as point of care tests. A little more of that later. Next, please. So that's how these amplification techniques are very important. Now, there are some of the newer technologies in isothermal amplification assays also. So when you use isothermal as against the conventional PCR, you are reducing the time. So the time to result is also reduced. And the examples here are the LAMP, TMA, transcription mediated amplification, strand displacement amplification, helicase dependent amplification, recombinase polymerase amplification. So all of these, out of these, LAMP is very commonly used for NG and CT, Neisseria gonorrhoeae and Chlamydia trachomatis in endocervical swabs. So the others are all in the trial stages, various stages of trial in several countries, mostly in Africa. And there are integrated platforms also that are being used now. Again, more of this is being done in other countries, but you must know that these are some of the newer techniques which are coming into play in STI diagnosis. Next, please. So other than amplification techniques, we are also moving into some newer technologies and non-amplification techniques. Some of these include the MAMEF, that is microwave accelerated metal enhanced fluorescence, which is believed to detect the Chlamydia trachomatis infections within 9 minutes, because it can also be designed as a POCT, point of care test. Then there are biosensors where nucleic acid binding proteins are used. All of these, I'm sure all of you are familiar with CRISPR because it's being used in many of the infective diseases. And so these are all programmable nucleic acid binding proteins, and the future is bright as far as uh, gonococcus is concerned, especially because the AMR, that is drug resistant detection, may become possible in Neisseria gonorrhoeae and Mycoplasma genitalium, where it is a problem now. So for CT and MG, it's very difficult to do the drug resistance testing. Next, please. Then you have newer technologies like microfluidic assays. Here you can detect multiple analytes. So it's a multiplexing system. From a single sample, you can get many. And this has been found useful in HIV and syphilis. And there are several trials still on in Africa. It's a very promising approach because, again, they can be made into POCTs and where the results can be just read with small battery-operated, battery-powered devices. Next, please. So there is DNA microarray also. Again, they say lab on a chip. So microscopic DNA molecules, they are called the reporters, which are attached to a solid support system, and then fluorescently labeled DNA RNA strands from the specimens. They are incubated with these chips, and with a scanner, you can read the fluorescence of the hybrids. Next, please. Next, yeah. So here again, liquid array. Again, here multiple diseases can be diagnosed in a single tube, that is in a single well. Next, please. So we move on to the sequencing technologies. Here again, the STIs have not lagged behind. Again, the nanopore technology for purification of the nucleic acid material and the genome-wide scans, they can be performed rapidly as well as at a low cost. And NGS, that is next generation sequencing technologies, they are being used to identify and characterize the pathogens with STIs. They contribute to being more accurate and comprehensive for the diagnosis. And then whole genome sequencing, again, this is going to be very useful for surveillance because AMR in gonorrhea can be detected and by use of WGS. And again, that will be very useful to handle the drug resistance problem in gonorrhea. Next, please. Then the omics, that is, you have the metagenomics, the culturomics, proteomics, all of these, they are showing a lot of promise, mostly because they can be multiplexed and also because they are fast and they are accurate, sensitive, and there may not be any need for culture as in metagenomics. Culturomics, the use is because in diagnosis like bacterial vaginosis, where you can't pinpoint one single bacterium, there may be a group of bacteria which cause the disease. In such conditions, for diagnosing these conditions, it shows a lot of promise, the omics. Next, please. Yeah, and antimicrobial resistance detection. Again, this is very important because there is widespread resistance to penicillin, tetracyclines, and fluoroquinolones. In fact, fluoroquinolones, especially ciproflox, which was one of the most useful drugs to treat gonorrhea, has now become absolutely useless because there is 100% resistance in our lab as well as the entire country, because we get all the gonococcal isolates from other labs, because our lab is the national reference laboratory for gonorrhea. So all the laboratories in the country who are linked with our lab, they send their gonococcal isolates to us, and we find that ciproflox and is 100% resistant. So it's really gone out now. And penicillin tetra are also resistant, and there is emerging resistance in azithro and ceftriaxone. Ceftriaxone, it's not exactly resistance, but it is less sensitive isolates. And azithro, we are getting resistance a lot now, so much so that we may have to think of revising the national guidelines, because as of now, the guideline says cefixime and azithro are given as dual combination drugs to treat gonorrhea. So the concern is loss of effective single dose therapies. Now we have to resort to two drugs or more. And the mechanisms of drug resistance in Neisseria gonorrhoeae, there are many. One is the PPNG strains. Then you have the cephalosporin resistance is usually due to the PNA gene mutations. Then efflux pump regulations. Then fluoroquinolone resistance is by the GAIR-A mutations. So to detect all these resistance genes in Neisseria gonorrhoeae, the whole genome sequencing is what is really going to help. So that becomes very important. For the whole genome sequencing is going to play a very important role. And surveillance, I've written EGASP and GISP here. EGASP is the Enhanced Gonococcal Antimicrobial Surveillance Program. This is a program which is started by WHO in all the WHO collaborating centers across the world, where the surveillance is being done for to survey the gonococcal drug resistance. So our lab and our country is also a part of this EGAS program, and there are 24 laboratories in India who have been identified to participate in this. So when we get to know what the drug resistance scenario is, we'll be able to handle the infection, that is, handle gonorrhea better. Next, please. So that's about some of the techniques that are upcoming. So what about the advances and the newer technologies in serological diagnosis? So serology is very important because, in fact, that we depend heavily on serological tests for HIV diagnosis, and of course other STIs also. Now the fourth generation rapid HIV tests have come, where you look for both antigen and antibody in the same test, and this will be useful in reducing the window period of the HIV infection. And there is enhanced sensitivity of these assays because now they use cloned proteins and recombinant antigens to make it more sensitive and specific. And the antigen detection assays, they suffered from low sensitivity, so we would not recommend many of these antigen detection assays. But now they are still useful, because especially CT and TB is trichomonas vaginalis, in high prevalence areas they may still be useful. And how can these antigen detection assays be improved? We can improve them by use of artificial intelligence and automated strip readers, where you don't depend on the visual interpretation, because which may be subjective, isn't it? So we can improve these tests by adding automated strip readers and by use of artificial intelligence. And the antibody tests, they are also improving now. You're getting newer tests like the syphilis tests, where you have both dual antibody testing, both the treponemal antibody and the non-treponemal antibodies are being tested in one test, which will be very useful, because what we do in the conventional diagnosis of syphilis is test by a the conventional method is test by a non treponemal test, and if it's reactive, you confirm it with a treponemal test. Or there is also something called as a reverse algorithm, where you test with the treponemal test first, and if it comes positive, you follow it up with a non treponemal test. So rather than doing all that, if you can have a test which can detect both by both methods, treponemal and non treponemal, that would be the best. And we are having tests like that now. And then there is multiplexing and immunoassays for CT, especially for CT and NG, chlamydia trachomatis and Neisseria gonorrhoeae, using microfluids and biosensors. They are all in the pipeline. And Duplay ELISA, that is where the ELISA test can be done simultaneously for HIV antibodies as well as syphilis antibodies with just a finger prick sample. And this can be operated by a smartphone. So these are all best for field testing. And you have to have more and more of these in STI diagnosis. Then, of course, nanotechnology combined with immunoassay is being tried out for as quantum dots, which increases the potential for multiplexing. Next, please. Yeah, and now we come to another interesting concept of newer diagnostics, that is self collection and home testing. Now, all of you know that STDs are, unlike other diseases, these are the Gupta Rog, or a lot of stigma attached. So people don't really want to be seen entering an STD clinic and all of that. So we have privacy enhancing methods and digital result delivery. And a lot of this, although not that common in India as yet, although it has made its entry, more in the US and all, you can say, they are the telemedicine integration is very common there, where all you have to do is go online and just say that I want to get an STD test done. They will ship the collection kits to you, then it will reach your home, you collect the kit, and then you collect the sample the way it has been described in this picture. And then you, after collecting the sample, you arrange for it to get picked up. So it gets picked up from your home, and a distant lab will be performing the test, and then the report will be online, or on your mobile you will get the report. So this is being tried for HIV, CT, and NG. The only disadvantage with these tests is that some of them are not yet FDA approved, and also for tests like syphilis, it needs blood sample and serum, so then you cannot do it. But for other swabs, collecting a urethral swab, urine sample, or vaginal swab, for all that you can still use this. In fact, in the US, it's becoming very popular, called as the IWTK kits. That is, I want the kit. This is how popular it is. I want the kit. Okay, next, please. Yeah, so to sum up the STI diagnostic syndromes, you have the urethral discharge syndrome, vaginal discharge syndrome, genital ulcer, and genital warts, and all of these. Here, the existing technologies and newer technologies, this gives a kind of a screenshot of that. You can see that most of the newer technologies are NAT based, or they are the point of care tests and multiplex tests. So that's the way forward, and that's where we are all heading. Next, please. So now coming to another interesting part of the talk, that is the fast world of today. This generation means you, all of you. This generation wants everything fast, whether it is your pizza or your other items, you want it in the blink of an eyelid. So everybody is into blink it all the time. So the lab is not lagging far behind here either. So we have to cater to what this generation wants, everything fast. So sample in, result out. That's what everybody wants now, and we are going in for the point of care tests because of this. So the rapid tests, the use is they improve the case finding and screening and diagnosis of asymptomatic cases is possible, shorter time to treatment, reduced STI transmission in the community, reduced clinic visits, and they reduce the sequelae and overtreatment, for example, in CT and NG, improved antibiotic stewardship, affordable, accessible. They improve the specificity of the syndromic management because I told you, syndromic management, the treatment is given without lab tests. But if you can have a lab test which is very fast and within 20 minutes to half an hour or 10 minutes, 20 minutes, if you can give the report, then you can might as well do that and give a more accurate, treatment for. So it enhances the syndromic management. That's why it's called the enhanced syndromic management. And some of the math models, they estimate that if you had POCTs, that is point of care tests for syphilis, it could save about 2 lakh lives and avert about 2 lakh stillbirths. So also for HIV, they say it could prevent about 2 lakh HIV infections per year if you could have fast tests. Next, please. But there are characteristics. WHO has laid down the assured criteria for the POCTs. Assured means they have to be affordable, sensitive, specific, user friendly, robust, rapid, equipment free, and diagnostic kits. So, to that, they have added RE, that is reassured, real time connectivity, and ease of specimen collection. So, if you have all of these, then if these criteria are fulfilled, you will have the ideal point of care test available. So remember, quality assurance is a point that has to be factored in into the POCT. Next, please. So, what are the principles of rapid POCTs? Earlier, the POCTs were all based on agglutination reactions and immunochromatography, immunoconcentration, and all of that, where we had multiplex testing, and we are still using all of them, in fact, for HIV and syphilis. But now, the emerging technologies, as I mentioned earlier, with the microfluidic assays and the rapid molecular assays, they are also getting more and more rapid. That is, they are getting improved. They're being designed in an improved manner to make them rapid POCTs, that is point of care tests, so that they will be accurate, also sensitive and specific and fast. Okay, that's what the aim is. Next, please. So let's see some of the individual POCTs available. For gonorrhea, you have the BINX, IOCT-NG. It's a combined test for CT and NG, chlamydia trachomatis and Neisseria gonorrhoeae. Within 30 minutes, you can get, it's based on real-time PCR from urine samples, and it can be males. Then expert, that is the gene expert CTNG based on real-time PCR. You have the WISB sexual health test. Then the LIAT CTNG MG test. This is a multiplex test that is they have applied for FDA approval. And for syphilis, we have the point of care tests, which is multiplex point of care test, which includes HIV, syphilis, hepatitis B, hepatitis C. This will be very useful in rural setups, especially in the pregnant women in the ANC clinics. And syphilis health check also, which is a rapid finger prick test where you can get the test in about a result in about 15 minutes. Okay, next, please. So for HIV, we've had POCTs for a very long time. The OraQuick was a very, very old test. And now you have newer tests which are designed for pediatric setting and for also even rapid tests, POCT tests for CD4 count also, and for viral load. So I think that will be the ultimate where we can do the viral load also as a POC assay. Next, please. Yeah, other STIs, they are not left far behind. For Trichomonas vaginalis and for bacterial vaginosis, also we have POCTs which are in the offing and which have shown some very good sensitivity and specificity. Next, please. And in the pipeline, we have POCTs where you can the cartridges for fully automated, where you just load the sample and forget it, and you will get the result. Then the built-in analyzers, barcoded internal controls, a closed battery-operated system, and based on real-time PCR and isothermal. And this includes these MAMEF and the nanotechnology PCR, POCTs, where multiplexing and quantitation is also possible. Next, please. So we've spoken so much about the POCTs, but please remember it's not the perfect kind of situation, because in order to use that, there are a whole lot of other things that must be put in place first. For example, the policies, the guidelines have to be laid down, the cost implications have to be worked out, and the what kind of test to do and where to do, who will do it, how to train personnel, and most importantly the quality control of these. The more rapid tests that you have to concentrate on the quality assurance. Next, please. So the challenges would be that it has to fulfill the reassured criteria, and reaching out the product to those with greatest need. So where it's exactly needed, that's where you have to link it. And the cost has to be worked out, as I told you. Education, training, the protocols, and quality assurance, surveillance, and for partner services. All this has to be put into place. Only then they will be useful. Next, please. Yeah, and in the end, I would just like to tell you that the rapid tests and POCTs, they are not the same. We use it in the same breath, rapid POCTs. But then please remember, the POCT, all POCT tests are rapid tests, but all rapid tests are not POCT. Because in order to call it point of care test, it has to be simple, and it has to be, you should be able to perform it in the field. Minimum training should be required, and no equipment should be required, and it should be quality assured. So all your rapid tests are not that. So for example, if you have to use a centrifuge, or if you require electricity to perform a rapid test, so then it doesn't become a POCT. Example, your gram stain. Gram stain is a very rapid test, means in 10-15 minutes you can do it, but it requires skilled personnel, and you may require a microscope. And the RPR test also, it's a rapid test but not a POCT. And the wet mount, whiff test, all of these, because they may be rapid but they are not quality assured, and they don't fulfill all the assured criteria. So remember, all rapid tests are not point of care tests, but all point of care tests are rapid, because the results are given in about 30 minutes or so, 20 to 30 minutes. Next, please. So remember, with all of this, you remember that there is no single optimal test for detecting the STIs. There may not be a single test. It's not like one lock, one key. It's more like a Swiss knife, where you pull out whatever you want, and as per your need, you use that particular test, which is useful for that situation and that that kind of setup. Next, please. So how do you select them? It depends on what you want. If you want speed, go for real-time applications. Whereas if you want a low throughput lab, it is, and you can do it at your own time. If it's for research and all, you can use the culture techniques and the block-based PCR and all that. And quantity, if you want multiple targets, go for multiplexing or microarrays. And if you want quantification, choose the tests accordingly. So depending on what you want, you have to use that in a very prudent manner. Next, please. So remember, an ideal laboratory may not have, it's not just the technology, it's a whole lot of other things like infrastructure, technology, personnel, because you have to have skilled people, and then quality assurance of the lab, maybe accreditation and all of that, and data and access, plus collaboration with your clinicians. Remember, the clinicians are the ones who give you the samples. So you have to collaborate with them, and you have to get from them the kind of sample that you want, right? Next, please. So with so many things in our armamentarium or in our kitty, the laboratorians, we can't just bombard the clinicians with all these names and things. We have to decide what is good and what is correct for that particular scenario, and accordingly the clinicians, because they cannot comprehend all of this, so we have to tell them. The cooperation between the clinician and laboratorians is very important, where we have to tell them what test is best suited for what kind of disease, and so accordingly. So instead of just bombarding with a whole lot of, if they just hear all these terms, they will just get confused. Next, please. So that finishes the diagnosis. Then some quick slides on recent advances in STI treatment and surveillance. So you know that gonorrhea, Neisseria gonorrhoeae has now become a superbug. It's also classified by WHO as a priority 2 pathogen. So where the need for new treatment strategies and antimicrobial stewardship and all of that is required, because you have the MDR, XDR isolates. In fact, in my own lab, we have isolated MDR and XDR isolates, which is quite alarming. And global surveillance, they have the WHO EGASP, the GASP, the CDC GISP. GISP is more in, it's in USA, and some of the Western countries use this term. And the AMR detection by PCR, whole genome sequencing, I said that already. And the current CDC guideline says high dose of ceftriaxone monotherapy. They have done away with azithromycin, whereas in our country, azithro is still being used as the combination drug along with the cefixime. And the newer drugs in the pipeline are zoliflodacin, gepotidacin, and solithromycin. In fact, my lab, I was involved in an international project where gepotidacin was being tested with the Neisseria gonorrhoeae isolates, and it seems very promising. And treatment, doxypep. Now, what is doxypep? Doxy post-exposure prophylaxis. This is a strategy where they give doxycycline within 72 hours of sexual exposure, and to prevent the STIs. And this again is showing promise in reducing STI incidence. Next, please. So there is an updated STI color-coded kit also. You must have seen this color-coded kit chart in all the, at least the government hospitals I know, they all have this, because for the syndromic management, these are the color-coded kits that are used for treatment. But here it has been updated, and they have added cefixime instead of 400 mg. Now the 800 mg has come in, and some other changes also. You can go through this kit. I think it's available online also. Next, please. And now, what's new in the HIV/AIDS scenario? We have moved from the 90-90-90 target to 95-95-95 target, because the 90-90-90 target was 2020, and many countries across the world had not reached the targets. So now it has become 95-95-95 by 2025, and we are already halfway into 2025, and we are still not really reached the 95 target. So what is this? Now, the first 95 is 95% of people who are HIV positive should know their result. That means they should have been tested. And the next 95 is 95% of people who are HIV positive should be put on treatment. And the third 95 is 95% of people who are put on treatment should show that undetectable levels of the virus. So we are we are really racing against time to achieve these targets. And NACO also has the Sustainable Development Goals for 2030, where we want to reduce the HIV infections by 80% and reduce AIDS-related deaths by 80%, and eliminate the mother-to-child or the parent-to-child transmission of HIV. So for this, we have the Early Infant Diagnosis Program, EID. And there is also a concept of SSS, that is Sampurna Suraksha Strategy, which they have rolled out, where you provide HIV prevention services for population at risk. That means the high-risk groups are caught, and they are given the preventive services. And there is a harm reduction program also for targeted intervention, like for IV drug users, intravenous drug users, and for behavior change. They are putting in all these programs. And scale up of laboratories for viral load labs have increased. We have about 64 of them in the country. Then STI labs are being upgraded, they're NABL accredited, so the quality is also being improved. So a lot of work is going on to enhance to reach the targets in this field. And what is U equal to U? That is, undetectable is equal to untransmissible. This is the mantra now. They say that if a person is taking ART very regularly and his viral load is virus is undetectable in his sample, then he or she is supposed to be untransmissible. That means they cannot transmit. So that's a very good thing, and this is what is being followed now. Next, please. So for HIV treatment, also the newer aspects are the PrEP, that is pre-exposure prophylaxis. Remember, when you say PEP, it is post-exposure prophylaxis. When you say PrEP, it is pre-exposure prophylaxis. So giving the drugs, medicines before the person gets the infection. That is also being tried out in HIV. And there are new long acting, I think last week, I think it was in the papers, all of you must have read, lenacapavir is an injectable medication that can be given for HIV treatment. And so it they this way you can, the person doesn't have to keep coming every taking those popping those pills every day. Then there is gene editing therapy going on, immunotherapy going on, new class of drugs like capsid inhibitors and entry inhibitors. These are all again coming into the fray. Next, please. So recent advances finally with vaccines. So STI vaccines are required because the behavioral risk reduction has its own limitations. You can't just stop. I mean, STDs are here to stay because as long as there is sex, and it's one of the oldest diseases known to mankind, as long as there is sex, there will be sexually transmitted diseases. So behavioral risk has its limitations, risk reduction. But so we need vaccines and use of PrEP for HIV. It may prevent HIV, but there is a rise in the bacterial STIs. This is what has been seen. So we need to work on vaccines for bacterial STIs and increase drug resistance in NG, MG, and all these diseases. Cost, affordability, and neonatal outcomes can improve. So for all of these, we need to go for vaccines. Next, please. So for HIV, we know that the only two vaccines so far available for sexually transmitted infections are the HPV, the human papillomavirus vaccine, and hepatitis B vaccine. But research is now on for HIV and other vaccines. Though there are no vaccines as of now with HIV, they are in various stages of clinical trials. And HPV vaccine has even got included in the immunization program in several countries. Next, please. So the STI vaccines in various stages of development. This chart just shows you that uh, the first stage vaccines are TB and NG and TP. They're all in the first stage. Whereas the advanced level phase 2, phase 3 trials, you have mostly the herpes simplex virus vaccines. And some of these are for recurrent cases and some are for the primary, to prevent primary infection. Next, please. So now the last is recent advances in public health interventions. I just thought I'll wind up with this because it's important. Targeted intervention, that means the government is now trying to target interventions of some high risk groups like the men having sex with men, intravenous drug users, commercial sex workers, transgenders. So all of them are being targeted. So when you target your interventions, you achieve more. Okay. And behavioral interventions are also on, and electronic health records are being maintained. In fact, all of us are part of the SOCH program where we have to make the entries, and everything is now available. The data is available with NACO online, because on a daily basis, in real time, we are giving out, punching in all the details onto the system, onto the online portal. Then biomedical interventions like medical male circumcision, maybe it can help, and microbicides, then partner treatment, pre and post exposure prophylaxis for STIs. So all of these are also important in the control measures. Next, please. So yeah, this is my last point. That is WHO global strategies. Now they have recommended to improve surveillance and early diagnosis and screening of asymptomatic individuals. The diagnostic algorithms have to be improved, and they want us to enhance the syndromic approach. That means enhance it with all the POCTs and molecular assays that we have, and quality assured molecular assays. That means the labs have to be well equipped and quality assured and accredited, and interrupt transmission, and also treating of sexual partners. Next, please. So please remember that the laboratory report is only as good as the samples received from clinicians. So do not, so always take the clinicians along, and we as laboratorians have to work in tandem with the clinicians. Next. Yeah, these are my references. Next, please. And thank you for your attention. This is a book I have edited. Please go through if you get the time. Thank you so much. Thank you, Dr. Sonal, for this opportunity. And I'm sorry there was an initial glitch, but I think I've managed to finish in time. Thank you, Nikita, for this, you know, the life saving strategy in the end.
Yeah, thank you, Dr. Sumati.
Thank you.
Yeah, so there is one question which I can see. CMIA is fourth generation HIV test. I think somebody wants you to confirm it.
Uh, this fourth generation tests are those where the antibody and antigen are detected in a
Mhm.
single thing. So we have usually the fourth generation, the it can be an ELISA, it can be any other format, wherever you it's called the fourth generation. Usually we refer to the ELISAs here, fourth generation ELISAs, which are given to the blood banks, where the antigen and antibody are both detected in one test. Okay. In fact, now you have even a fifth generation ELISA, fifth generation test, where uh, apart from an antigen as well as antibody, the HIV 1 and 2 can also be detected. So we need all of this because in blood banks, when you have to decide on the donors and all of that, the donor samples, you have to reduce the window period as much as possible. So those are um, uh, the fourth generation ELISAs. As far as I know, where you detect antigen and antibody are usually the ELISAs.
All right. The other question is anything related to any update on HIV drug resistance, any NACO guidelines for testing and therapy?
Yeah, now NACO has, we recently had a meeting where they decided that HIV drug resistance is also a major issue, and some of the labs are being earmarked for performing this. So they're going to roll out that in the next phase 5. NACO is now into its the next phase of its, program. So NACP 5 is now giving rise to the NACP 6. So in that, the focus will be on all of these drug resistance labs, which will do drug resistant testing. So that is on the cards.
What are the implications for the use of lenacapavir in, I think, pre-exposure prophylaxis,
See, as
efficacy, acceptability, and safety profile?
Yeah, as of now, safety, acceptability, all of this in India, at least, we cannot comment on this because it's just about been launched, and it is still very expensive. If you saw the papers, I think it said the cost would be something like 64 lakhs, which is again, I think it's unaffordable as of now. So we'll have to wait and watch, and of course, have our own or make in India drugs when we have, and when the cost comes down, then we'll know more about all this acceptability, safety, efficacy, and all, when our own people are starting to take it. So right now we only have Western data.
Sure. I think with that, yeah, that's the last question. Thank you, Dr. Sumati. Thank you for taking our time. And thank you, Nikita, for bailing us out at the last
Yes,
minute.
thank you very much. Yes, yes, thank you, and
Thank you.
thanks, Dr. Sonal.